The topic is evaluation of a child with strabismus. I'll be using this outline, and this is a picture of a child with an obvious squint. All right. By way of introduction, strabismus, which is also called squint or crossed eyes, refers to misalignment of the eyes as a result of deviation of one or both of the eyes. It can be from a lesion intrinsic to the extraocular muscles. We do know that the extraocular muscles are responsible for the movement of the eyes, as well as the innervation of those muscles and control from the higher centers. The strabismus could be isolated or associated with other ocular or systemic anomalies. It can interfere with binocular vision and perception of depth. Strabismus can affect the social development and quality of life, especially in children. All right. So strabismus is seen in about 2 to 5% of children in the world population. In Nigeria, the values I got were very diverse. So I just put it as from 0.01 to 2.4% in Nigeria. It can affect every age group, but is mostly diagnosed in children. The risk factors for the development of strabismus include a genetic predisposition in which you see generations of a family having strabismus. Refractive errors are the commonest causes of strabismus. Then prematurity and low birth weight can also be risk factors for strabismus. Then certain syndromes also present with strabismus. Now, what are the aims of evaluating a child with strabismus? It's important to establish the cause of the strabismus, to assess the binocular sensory status of the child and see if something can be done about it, measure deviation, especially with the aim of doing a surgery to correct the strabismus, then diagnose amblyopia, guide treatment decisions, and monitor and follow up the child. It's important to classify the strabismus because this will help you know which investigations to do and which modality of treatment to follow. So I have a mnemonic, hard face. So it helps me when I'm reviewing the child or when I'm examining the child. So you want to know, is the strabismus hidden or revealed, which is the classification that we usually say, a manifest strabismus or a latent strabismus, or is it atropia or aphoria? So it's if the strabismus is either hidden or revealed, it's a way of classifying the strabismus. Also, the age of onset of the strabismus is another way of classifying the strabismus. Is it congenital or acquired? Is it occurring before the age of 6 months or after the age of 6 months? So we want to know that. Then the direction of deviation. Is the deviation horizontal? If yes, is it towards the nose or away from the nose, towards the ear? Or is it up or down? Or is it torsional? You want strabismus can be classified that way and can also be classified based on the pattern of fixation. Is the patient fixating with just one eye or it alternates between the two eyes? Is it actual or apparent? Does this child actually have a strabismus or it's an apparent strabismus, something that looks like a strabismus but actually isn't? Is the angle of deviation the same in all directions of gaze or not? Then is the strabismus, is the deviation always there, or are there things that bring out the deviation? So that's another way of classifying the strabismus. Then is it primary or it's secondary to a lesion, possibly maybe an entrapment or something? So um, these are ways of classifying strabismus. Now, in evaluating a child with strabismus, the first thing you do is to get a history from most times the parents. And they usually present with complaints of eye deviation. You see a mother telling you, my child's eyes are not straight. So that's usually the chief complaint. So for the examiner, you want to know, is it one eye that is not straight, or is it both eyes, or does it change that in this situation, one eye will be deviated and the other eye will be deviated? So you want to know which of the eyes it affects. Also, you want to know the age of onset of strabismus, because usually In some conditions, there's the transient deviation before the age of 4 months. So by 6 months, if the strabismus is still there, you know that, okay, yes, this is not the transient form of strabismus. So you want to know the age of onset of this strabismus. Also, the direction of deviation, you'd want to find out from the mother. Now, you want to also find out if it's spontaneous or if it occurred following trauma, following a febrile illness, or anything that presented the event, that preceded the event of the strabismus. You also want to know if there's progression, if from the onset of the strabismus to when the child is presenting to you, if it has been stable or if it's getting worse or if it's getting better. You also want to know the pattern of presentation of this strabismus. Is it always there? Is it intermittent? Is the strabismus there when the patient looks at things that are far or things that are near or in any direction? You want to know that. You also want to know if there are precipitating factors. In intermittent exotropia, it usually presents after a a period of phoria. If the child has had a latent kind of exotropia, then when the child is having some form of visual inattention, the eye may deviate out, or if the child is fatigued or on exposure to bright light, the bright light dazzles the retina such that fusion is broken between the two eyes, and then you see the eye deviating. Then, in some cases of illness, debilitating diseases can present with deviation of one eye. Now, you also want to know if there's variability in the kind of deviation. Does it get, is the deviation seen based on the time of day or maybe fatigue, or does it vary with the direction of fixation? You want to know all of that. Then, is it associated with symptoms like poor vision, diplopia in older children, asthenopia? You want to know that. Like I said, in intermittent exotropia, there's photophobia that causes the eye to deviate. Then your mothers can actually tell you if there's a compensatory head posture. They'll tell you, oh, my child actually has to turn this way to see objects clearly, or he bends the head or he elevates the head. Then in patients with refractive error, of course, because that eye is not seeing well, you find the child poking the eye or rubbing the eye or actually half shutting the eyes to see. So that will tell you that it has a refractive component. Then strabismus is one of the common findings in retinoblastoma. So if you have a child presenting with strabismus, you want to rule out retinoblastoma. So you ask the mother, if they have noticed any whitening in the pupil. So that will guide your further evaluation. Also, are there abnormal eye movements? Is the eye having uncontrolled movement, or in attempting to look horizontally, the eye deviates up or down? You want to know all of that. Then, has the child had any form of intervention? Has he had any form of patching? A lot of children do not cooperate with patching because some of these children are syndromic and they usually do not comply, so they can yank off the patch. So you want to find out from the mother, has he had any form of patching? Was there compliance? Was there any improvement following patching? Or did you have to change from patching to actually using things like atropine to fog the eye? You want to know all of that. Was there a history of spectacle wear? For how long did the child wear the spectacle? Did it result in any improvement in the strabismus? Or was there any reason for the discontinuation? You find parents saying, oh, my child is very stubborn. I've bought glasses like 5 times. I'm not buying again. But then you have to explain to the mother that the child has to continue with it so that it will help improve the strabismus. Then, has the child had any recent refraction? You'd want to know that as well. Then, has the child had orthoptic intervention? Pencil push-up is a form of orthoptic intervention where something, a small object that the patient, because they are usually children, something that will catch the child's fancy, you keep bringing it close to the eye. That's usually used for exotropia, so that the child is forced to converge the eyes, and it will help improving the strabismus. So you want to know if they have done that, if they were compliant, if there was any improvement as well. You want to know if the child has had a previous surgery. Some of these patients may present to you. What they have is a consecutive strabismus because they may have gone somewhere else. They had maybe in trying to correct an exotropia, the exotropia is overcorrected. Now the patient has a consecutive esotropia. Some of those parents will not volunteer such information except you ask them, have they had surgeries before? And if you don't know that, you may try everything you can in managing this patient, but there will be no improvement. So you need to have an idea of what has happened. You need to be sure that it's not something, a form of consecutive strabismus. If the child has had a surgery before, is there any record for it so that at least you can have an idea? Yes, he did a surgery, so millimeters of medial rectus was resected, so millimeters of lateral rectus was recessed. So you need to have an idea of that so that if you have to take the patient back to the theater, you know what you're doing. Also, you want to know for older children or other children, you want to know if they've had something like a retinal detachment surgery where the buckle is entrapping a an extraocular muscle, or other forms of surgeries that could affect the extraocular muscles. It will help to guide your management. Also, in the history, you want to know, is the patient a sickle cell disease? This can also cause a strabismus. Or are there other neurological deficits, cerebral palsy, Down syndrome, and all of that? Such patients usually come down with strabismus. Also, for the family history, we've said that one of the risk factors is genetic predisposition. So we want to know that as well. um, it's important to ask to see previous photographs so that you know and confirm what the parent is saying. All right. The pregnancy and birth history is also very important. Were there significant events? Was there a febrile illness during pregnancy? We want to know if the child was born prematurely, if the birth weight was adequate, or if there was some form of birth trauma that affected the extraocular muscles. We want to know that as well. Then neonatal infections, jaundice, birth asphyxia, some of these things can cause some neurological deficits that will eventually affect the eyes and cause strabismus. We want to know about the developmental milestones. Some of these patients with syndromes have developmental milestones, and they could also come down with strabismus. The immunization history is also important. We're not just managing the vision or the eye of the child, we also want to know about the general health of the child, because there's no point in having straight eyes when your general health is going down. So you want to know about the general health status of the child. Now, for the examination, we want to check the child generally to find out other systemic conditions that may be linked to the strabismus or maybe the cause of the strabismus. So we're looking at the patient. Are there some form of syndromic facies we're seeing in the child? Are we seeing low set ears, widened nasal bridge and all of that, or broad epicanthal folds? We're looking at all of that to see if there are some syndromes that are linked to this child so that we can refer the child appropriately. Want to check for facial asymmetry. We're checking for lid fissures. That will also guide us in our further examination and treatment. In something like Duane syndrome, we have narrow palpebral fissures. In Brown syndrome, we have widened palpebral fissures. So this will further tailor guide your for your other evaluations and management. We're checking for the epicanthal folds. I've mentioned earlier that there's this concept of pseudostrabismus. In a child with large epicanthal fold, it may appear as though the child has esotropia. But by the time you do some other investigations, you realize that that's just um, a pseudostrabismus. Also, abnormal head positions, you want to look out for it. For the face tone, it gives a pointer to the fact that the child has a horizontal strabismus. For the head tilt, usually a vertical strabismus. For chin elevation, a lot of times, some of these, if for instance, a child has a third nerve palsy, you're seeing a child with exotropia and a ptosis. The child will want to, because the eye is down and out, and the ptosis is almost covering the eye. So you see the child elevating the head to see. So that gives you an idea of other investigations to do. Um, Furthermore, we would want to check the visual acuity of the child. Visual acuity is usually um, age, the age appropriate visual acuity for the child. You don't just have a 6 month old and you are presenting a visual acuity chart. So it depends on the age of the child. And a lot of times we are more concerned about the visual behavior of the child, because some of these children may not even cooperate enough to get a proper visual acuity. So we're looking at the visual behavior of the child. Want to check for a newborn child, want to see if the child blinks to light. As the child grows older, maybe at 1 month, want to see if the child is able to follow familiar faces like that of the mother. After a while, we want to see if the vision is central, if the fixation is central um, on the object of regard. There are also other examinations for visual acuity. We want to do some electrophysiological tests like VP for children that are aphasic, or you are unable to get any reasonable finding from the proper visual acuity tests. You'd want to do some electrophysiological tests. Then as the child grows older, the child should be able to match pictures or objects. You have a picture at 4 to 6 meters, and the child has some other pictures with her. So when you present a picture at a distance, the child should be able to point at whatever it is that you're seeing at distance. Then for the school-aged children from 4 years and above, the child should be able to name alphabets and all of that. So this is just a breakdown of what I just said. Yeah. So further in the examination of a child, you want to examine the anterior segment of the child. You're looking at the lids and lashes as well. You're looking at the epicanthal fold. Looking to see if there's a ptosis or a retraction. You're looking at the conjunctiva. You're looking at the cornea. Is there a corneal opacity that is contributing to a sensory um, strabismus? You're generally looking at the anterior segment to see if there's any ocular contribution to this strabismus. Now, for the squint evaluation proper, these are the investigations we do commonly. There are other investigations, but a lot of them are tied to what you're seeing from all of this. So, depending on what you're seeing, it will tailor guide your evaluation of other tests. Now, for the Bruckner test, is a gross examination and is actually simple. It's used in children, especially those who are not cooperating. So you want to have an idea of the visual status of the eye. So in doing this test, you project a light source to the eyes simultaneously. Ideally, the red reflex is supposed to be equal and equally clear or equally red in both eyes. But if you are seeing an eye that has a deviation from this normal, you are seeing an eye that is having a brighter and clearer red reflex than what you perceive to be normal, you know that there's either a gross reduction in vision in that eye or the eye is deviating. So it's a simple and easy test to do for preverbal children who are usually not cooperative. Right. So the Hirschberg test is a kind of corneal reflex test. There are also other kinds of corneal reflex tests. This test is done in children who are possibly not seeing well or who are unable to fixate on the object of regard because of poor vision or a sensory compromise in the eye, or children who are not cooperating. So it just gives a gross assessment of the angle of the measurement of the angle of deviation. So in this test, you project a light source to the eyes simultaneously. In the normal eyes, you are expected to have the corneal light reflex slightly nasal to the central part of the cornea. For patients with strabismus, the corneal light reflex will be decentered um, and depending on the position of the corneal light reflex, you are able to have an idea of the amount of deviation of this eye. So it gives a rough objective estimate of the angle of strabismus. It's useful in uncooperative patients and in patients with poor fixation. It also rules out pseudostrabismus. Yes, in a pseudostrabismus, by the time you project the light source to the patient's eye, the corneal light reflex is symmetrical in both eyes, unlike in true strabismus, where one eye is decentered, or even if it's both eyes that are deviating, you can see that they are not, they are both decentered. And you have an idea of the amount of deviation in that eye. So it estimates the distance of the corneal light reflection from the center of the pupil. The normal pupil size is between 3 and 4 millimeters. For the purpose of the Hirschberg test, we're assuming that the normal pupil size is 4 millimeters. So if the normal corneal reflex is supposed to be centered, if it is deviated, if it's decentered towards the pupillary margin, it means it's like 2 millimeters away from the center. And each millimeter is like 7 degrees of deviation. So if it's deviated pupillary margin, it means it has been deviated to an approximate value of 15 degrees. So that gives a finding of, if the deviation is 15 degrees, it's approximately 30 prism diopters. So that will help in your management to know how much resection and recession you are expected to do. And it will help to prognosticate as well as monitor and follow up, so that if after your treatment you are checking again and you're seeing that, oh, this corneal light reflex was initially at the limbus, now I'm seeing it close to the pupil, you know that you're making progress. All right. For the Hirschberg test, these are pictures showing what I just described. In the first picture, we can see the corneal light reflex at the pupillary margin. So this is about 15 degrees of deviation, which is also 30 prism diopters. In the other eye, we're seeing the left eye deviated in. So we're seeing the corneal light reflex at the limbus. So this is about 45 degrees of esotropia, which is also 90 prism diopters. In this third picture, we're seeing the eye deviated down and out. So there's an exotropia and a hypotropia. The corneal light reflex is also at the limbus. So that's like 45 degrees of exotropia as well as hypotropia. For the Krimsky and modified Krimsky test, these are also um, um, corneal reflex tests, but they are used to measure the amount of deviation. They give a more accurate measurement of the amount of deviation. So for the Krimsky test, the prism used to measure is put in front of the fixating eye while the patient is fixating at an object of regard. You keep increasing the amount of prisms until you are seeing that there's no decentration of the corneal light reflex. In the modified Krimsky, the prism is placed in front of the deviating eye. And the same thing is done. You keep increasing the amount of deviation until there's no obvious decentration of the corneal light reflex. The modified Krimsky is usually used for patients with larger deviations and in eyes that the vision is not really clear. They have poor fixation. So you put it in front of the deviating eye and you get your measurement. Now, for the cover tests, these are very important tests done in strabismus. But for this to be done, the child needs to have bifoveal fixation. The child should be able to cooperate with the examiner. He should be able to make eye movement, and there should be no latent nystagmus, because if the child has a latent nystagmus and you occlude one eye, the nystagmus worsens and the eye is all over the place. You're unable to get a proper finding. Also, in cover tests, you should have a sizable occluder that will occlude the peripheral vision, peripheral field as well, because it said that it's the peripheral input on the retina that drives fusion. So if you are not occluding the peripheral field, you have your results, your findings will be compromised. So it's important to do a proper cover test. Now, there are three main types of cover tests. There's the cover on cover, alternate cover, and the prism cover tests. All these tests must be performed at distance and near fixation. So this is a picture of a patient that a cover test is being done on. The cover test is done to reveal or to evaluate atropia. That's a manifest deviation. In the cover test, you occlude an eye as the patient is, because it's done at distance and at near. Your distance target is usually one or two lines above the best visual acuity for the deviating eye. So if, for instance, the fixating eye has a VA of 6.6, while the deviating eye has a VA of 6.18, you go one or two lines above the VA for the deviating eye. So you're going to like 6.24 or 6.36. So the patient focuses on that line, and then you occlude one of the eyes. You're looking at the eye that is open. So you want to see in which direction that eye is moving. So if the eye moves in, it means the eye was initially out. So that's an exotropia. If the eye moves out, it means the eye was initially in. So it's an esotropia. If it moves up, it means it was initially down. So that's a hypotropia, and vice versa. So you do that for the two eyes at distance and at near. The near target will be at 40 centimeters. There are some near test objects that the pediatric ophthalmologists usually have, but you can do something, use an object that will catch the child's attention, because some of these children, their attention span is usually very short. So you need to use something that will catch the child's attention. For the uncover test, it's done for children that have aphoria. The strabismus is not obvious. So when you occlude one eye, you give the eye some time to manifest itself. So you are giving like 2 to 3 seconds. So you close one eye, you count in your mind 1, 2, 3. You occlude the other eye. So what you're looking at is the eye that was initially covered. So by the time you expose that eye, you're checking to see if there's some form of refixation saccade. You are checking to see if the eye is moving to take up fixation. So if the eye moves out, it means it was initially in. So that's an esophoria. If it moves in, it means it was initially out. That's an exophoria. The same thing with the up and down movement. Now, for the alternate cover test, this is done after the cover and uncover tests. It gives an idea of the total deviation, both phoria and tropia. So in this case, you close one eye, count for your 2 to 3 seconds, occlude the other eye 2 to 3 seconds. Same thing, you keep doing that for each eye. This will dissociate fusion and reveal whatever phoria or tropia is left. It's also done at distance and near. Now, the prism cover test is the third type of the cover test. This is also done at distance and near, while the alternate cover test reveals the total deviation. The prism cover test measures the amount of total deviation. So you are doing an alternate cover test, but with a prism in place. So you keep increasing the amount of prism until you do not notice any form of refixation saccade. So this test is also done at distance and near. This test is actually very important in intermittent exotropia, in which you have subtypes. You have the distance excess, you have the basic, you have the convergence insufficiency. In these conditions, in the distance excess, the deviation at distance is over 10 prism diopters more than the angle of deviation at near. So when you do the prism cover test at distance and at near, you are seeing a difference in the angle of deviation of greater than 10 prism diopters. So you want to do some further tests because the cause of this may be as a result of a high ACA ratio, for which when you put in a +3 lens and you repeat the prism cover test, there's the difference between both distance and near deviation reduces. It now comes down to less than 10 prism diopters. So you know that for the management of this child, you are going to have to give a high plus lens. Otherwise, it may be because the normal fusional vergence is masking the deviation of the eye at near, which is what we call tenacious proximal fusion. So for this case, you have to occlude the eye for about 30 to 60 minutes. By the time you remove the occlusion and you repeat the prism cover test, you have a similar angle of deviation between distance and near. So that helps to tailor guide your management of this patient. So these are also very important tests. All right. The extraocular motility is also assessed for this patient. It's done with both eyes open. The patient is looking in all the 9 diagnostic position or directions of gaze. You're looking straight ahead. At the same time, you're asking the patient, usually in older patients, if there's diplopia, you also have your diplopia charting done. You're also checking for overactions or underactions. These are oblique involvement in the strabismus. So if you ask the child to look right, you are checking to see if the eye is looking maybe right and up or right and down. So you're checking to see if there's any vertical compromise in the strabismus as well. All right. So to check for binocular single vision, these are sensory tests. Some schools of thought believe that the sensory tests are done before you evaluate for the strabismus, because by the time you evaluate for the strabismus, some of these tests will break fusion. So you may not get um, the kind of finding you're looking for in the sensory tests. But some other schools of thought believe that it's important to do whatever tests you need to do and reveal every kind of strabismus possible. And then after that is done, you will now do the sensory test to see if the patient can still have a binocular single vision after fusion has been dissociated. So there are different schools of thought depending on what is done in your center or depending on what you believe. So Watford dot test is a kind of binocular single vision test. It's done using a Watford dot chart or object. You have a test object that has 2 green lights, 1 red light, and a white light. The patient is sitting at 6 meters. He's wearing red and green goggles. Now, for normal, you see the patient is expected, because the red and green goggles will dissociate what you're seeing. The right eye has the red goggles in the red part of the goggles in place. The left eye has the green part of the goggles. So this dissociates um, the eyes, such that the patient is now seeing. Ideally, the patient should see 2 green lights, 1 red light, and then the white light will appear as pink because of the impact of the red goggle that is in place. So this is what the normal eye is supposed to see. Now, if the patient reports that he's seeing only red lights, it means there's a left suppression, because the right eye is the one that has the red goggle in place. So that's all the patient is saying, because he has suppressed the left eye. So the patient has a left suppression. So same thing, if the patient says he's seeing only the green light, it means he's suppressing the eye that has the red goggles. Now, if the patient is seeing more than 4 lights, it means the patient has diplopia. So depending on the way the lights are arranged, you want to know if it's a horizontal or a vertical kind of strabismus. So that's, you're asking the patient, in which direction are you seeing the red, in which direction are you seeing the green. So that will help guide your further evaluation and treatment. In recording this, you will in recording the test for binocular single vision, because there are other tests that can be done, you have to state what exactly you used for testing binocular single vision. So that's important. Now, stereoptic evaluation is one of the tests done for patients with strabismus. There are different types of tests that are used. This, my slide is a bit crowded, but I just put all of them in one slide. We have the titmus test. This is a test that uses a Polaroid filter glasses. Then the titmus chart is presented to the child at 40 centimeters. So with the Polaroid glasses, if you can see this clearly, you can see that there are three different parameters here. You have the one with the fly, you have the one with circles, you have the one with animals. For the one with the fly, the child is expected to pick one of the wings of the fly between the thumb and the index finger. So that's used to test for stereopsis. And there are values written there. The lower the value, the better the child's stereopsis. So if you have a child, because depending on what they are seeing, the values are written at the back. So you can check to be able to have an idea of how much stereopsis the child has. So if you have a child that has a stereopsis of like 300 compared to the normal of about 60, you can see that the child does not have a good stereopsis. And for such a child, you should do surgery at your earliest convenience. So that's for the fly. For the circle, you want to see which of the circles, you're looking at all the circles and you ask the patient, which one are you seeing that is coming out, is bulging towards you? The child will touch it. You will now look at the grading at the back and see how to grade the child's stereopsis using that. Then for the animals, same thing. You want to see which animal appears different and is popped out. So that is for the titmus test. For the TNO test, it has random dots. You're wearing red green filters, red green goggles that will show random dots. But when the red green goggles also helps to dissociate. So when you look at it, there are some objects that the child, because of the red green goggles, there are some objects you are expected to be able to see. There's also the grading chart somewhere to grade the child's stereopsis. For the lung test, um, this lower one under, you can see a star in there. So in the upper one, you can see some objects there. So and the grading at the side. So if the child is able to pick out the object in these random dots, you go now and grade it from the chart, and then you have an idea of the child's stereo acuity. Then the frisbee test, there's a hidden circle in one of these. If the child is able to pick out the hidden circle, you'll be able to grade the child's stereopsis. So some other tests for strabismus include the Maddox rod or the Maddox wing. These are Fourier tests for Fourier. For the Maddox rod is used to test for Fourier at distance, while the Maddox wing is used to test for Fourier at near. Some of these tests are not routinely done. Is when you're having, you're not very comfortable with what you're getting from maybe the cover tests and all of that. You may want to do this and get your results. The Bagolini tests as well. This helps to detect binocular single vision for a patient that has straight eyes. If by Bagolini test, the patient puts on glasses that have striations like the Maddox rod test, but in this case, in the right eye, the striations are 45 degrees obliquely arranged. In the left eye, it's 135 degrees arranged obliquely. So the patient is looking at a light source presented to it. This, just like the Maddox rod test, where those striations give just one line, in the normal eye, the lines are expected to cross each other and form a cross. But in an eye that has a suppression, you only see the light produced by just one eye. So if you are seeing just the eye, the right line, it means you're suppressing the left. If you are seeing just the left line, you're suppressing the right. If there's a hole in the middle of one of the lines, it means there's a central suppression scotoma. These are also tests you do when other tests are not giving you the right results. Um, the PAC 3-step test, depending on the history, if you have a child presenting with a with chin lift, and he's trying to, you have an eye that has a hypertropia, you would want to do the PAC 3-step test, where there are 3 steps of the test. In the first test, you want to know which eye is elevated in primary position. Then in the second test, you want to check which if the hypertropia is worse on opposite gaze. And in the third test, you want to check if it's better on opposite tilt. So that's for superior oblique palsy. Then for the first duction test, you want to check if the strabismus has a paretic component or a restrictive component. There's also a test done. These tests are usually done after your history to give you an idea of what exactly to do. Then this synoptophore test is a test of binocular single vision. You can also use it to test for anomalous retinal correspondence. If you're having um, um, for instance, even in the Maddox, in the what 4 dot test, if the patient is seeing 4 objects and you're seeing that the patient has an obvious deviation, it means the patient has an anomalous retinal correspondence. He's seeing the 4 test because the fovea of one eye is having a correspondence with an extrafoveal position of the other retina to give you the 4 dots. So same thing with the synoptophore. If the patient is able to fuse the objects shown and you're seeing an obvious squint, it means he has an anomalous retinal correspondence. All right. So basal prism tests are also used to detect fusion in children. In this case, you put a basal prism before one eye. The eye, if for instance, you're putting the basal prism in front of the right eye, it causes the right eye to deviate towards the left. And based on Heron's law, the left eye will join it to deviate towards the left. But the left eye now realizes that, oh, I'm not meant to be doing this. And then it has a refixation saccade towards the primary position. And the covered eye as well is expected to follow it. So if that does not happen, you know that the child is not fusing properly. All right. Okay, so that's for the examination of the strabismus. You will also want to do a cycloplegic refraction, especially in children that you suspect that, in fact, in all children that present with squint, we want to check for a refractive component of the squint. So we'll do a cycloplegic refraction. You could use cyclopentolate for a child less than 12 months, you use 0.5%. For a child greater than 12 months, you use 1%. You use 1 drop every 5 minutes, and you expect cycloplegia in about 30 minutes. So the test has to be done within that 30 minutes and 2 to 3 hours, because the cycloplegic effect could resolve after about 2 to 3 hours. So the test has to be done. But it has been seen that for children that use cyclopentolate, they may behave with irrational behavior. There may be respiratory distress, tachycardia. So care has to be taken in the use of this medication. In the event that your child, a child you're evaluating, presents with such characteristics, you would want to give the antidote, which is physostigmine. Then atropine is what we use in my center. We give it to the parent of the child. They use it for 3 days. BD, 1 drop BD for 3 days before the day of the evaluation. So when the child comes to the clinic on that day, we do the refraction, cycloplegic refraction, and then we do a dilated fundoscopy. But atropine also has its own downsides. It can cause fever in the child. It can cause restlessness, delirium. If it gets into the systemic circulation, it can cause coma. So when we give it to the parent, we advise the parent on applying punctal pressure so that the amount that goes into the systemic circulation is minimal. And then if the mother notices any form of fever, even before, without that, patient should take ibuprofen or paracetamol to reduce the fever. Also, if there's atropine toxicity, we can give IV physostigmine to the child. Then homatropine is it has a close effect on cycloplegia to atropine, but it has less side effects. So it's commonly used for cycloplegic refraction as well. Then it's important to check for any ocular component of this strabismus. You want to see if the cause of this strabismus is sensory, if there's poor vision as a result of maybe a macular scar or or a vitreous opacity, corneal lens opacity, lesions in the retina. You want to check if the child has retinopathy of prematurity, in which there are scars in the retina that have pulled the macula away from its position, and then the angle of kappa is deviated, and you're having strabismus. So it's important to examine the back of the eye to see if there's any um, lesion at the back of the eye resulting in this strabismus. What we commonly use in my center for 1 ml per year. So it's important to know the exact age of the child. And it's usually used for children above 1 year old. Um, if the child is maybe 18 months, you want to know the exact age of the child in months. Because if the child is 18 months, you would want to give something like 1.5 mils of the IM paraldehyde. Um, because if you give just 1 mil, the effect will wear off very fast. So you have to give based on the age of the child up to 5 years. It's expected that at 5 years, a child should be able to cooperate for dilated fundoscopy. So IM paraldehyde is given, and the dilated fundoscopy is done on the table. Chloral hydrate is also used, and it's used in children less than 1 year. Um, then it's given orally, 25 to 50 milligrams per kg. This will all is a hypnotic sedative, so it helps to knock out the baby for a couple of minutes to hours so that you can examine. We usually leave examination under anesthesia in the theater to extreme cases, and then very small babies that we can't really get much on the table. And for children who are not cooperating, we do EUA because of the side effects of anesthesia, the cost of taking. Just because you want to examine for strabismus, a child is paying 100,000 as anesthetic fees, theater fees, this and that, something you could easily have done on the table. So we usually leave that till we can't till we have done everything possible to examine the child on the table, but we're not getting adequate results. We'll take the child to the theater. So there are lots of anesthetic complications that we don't want to have. But when all else seems to fail, we end up taking the child to the theater to examine, because we need to look out for retinoblastoma, because it's one of strabismus is one of the common findings in retinoblastoma. So we need to examine the extreme retinal periphery to see if there's any lesion. Now, for the investigations, we would want to do a CT or an MRI of the orbit and brain, especially if it's a sudden onset strabismus. We want to do a CT or an MRI to give an idea of a lesion in the orbit or in the brain. Now, for children we intend to take to the theater for EUA, we would want to do all the investigations that are requested for by the anesthetists. We want to do a complete blood count with differentials, and electrolyte, urea, and creatinine. The urinalysis will give a broad picture of the renal status of the child. We want to know, well, RVS, we want to have an idea. In conclusion, early detection and prompt treatment of strabismus are crucial They are crucial to prevent long-term complications. We do know how mean some children can be. They see a child with crossed eyes, they mock them till the child can possibly go to commit suicide. So there are long-term complications. There's amblyopia, there a lot of complications. So early management will help to prevent those complications. It helps to promote optimal visual development so that if any lesion is noticed early and it's addressed, the eye can then grow properly. Then it helps to boost the self-esteem of the child and to improve interpersonal relationships. Like I said now, children, you need to see what children do in schools. They will mock you to scorn. But if your eyes are now straight, you are better able, your self-esteem is boosted, you're better able to interact with people. Then amblyopia can result from delay in management of strabismus. So that's one of the reasons we manage these patients. We try to do our refractions. We try to correct the strabismus to see if it can help improve the patient's vision. All right. So these are the materials I got my the presentation from. Thank you very much.
Thank you so much, Dr. Theresa Ibebunjo. It has been an enlightening session. And thank you for making it very interesting. Typically, strabismus lectures cause some somnolence. However, in this case, still your stepwise approach have made it very rich and interactive. So I believe we'll have a lot of comments, discussions, and contributions from members of this session. I can vividly see our very senior and respected teachers on the platform. We'd like to welcome all and appreciate their input during this presentation, like Professor Adedayo Adio. You're welcome, man. All right, so let's go to the chat. Can you see the chat? Okay, you may need to scroll up.
Someone said, please, I need clarification on the statement that before a cover test is done in strabismus evaluation, that there must be a bifoveal fixation. The patient should be able to fixate with the fovea in each eye for you to be able to do a cover test. Otherwise, you will not get an appropriate result. I don't know if
Especially when they uncover, after uncovering the eye, they need to, if there is suppression or loss of vision in that eye, then it means the child cannot fixate on the
cannot
other.
fixate. Yeah, true.
I think you need to go up instead of down. Yeah.
Okay. That's all there is up
Okay,
there.
let me read out for you. We have some comments. Dr. Opara said, thank you for your presentation. Why is it that Bruckner test? In Bruckner test, the deviating eye is brighter as compared to the fixating eye.
Sorry, I didn't get that.
Why is it in Bruckner's, the deviating eye reflex is brighter as compared to the fixating eye?
I'm not sure about that, but that's just the way it is. Well, I'm not sure, but that's just the way it is. The deviating eye has a brighter reflex than the fixating eye.
All right, Dr. Adiogun, what is the explanation for the transient strabismus that may occur in children less than 4 months?
The eye is still developing,
Yeah.
so there could
Although,
you need to watch the eye to see if by 4 months the eye becomes straighter because the extraocular muscles are still developing, the eye is still developing, everything is still developing. So by 4 months, it's expected that the eye should be very well developed to be able to maintain fixation. So you're checking the child to see if by 4 months, because there are people that have presented, they come at 1 month, they are complaining, oh, my child's eye is not straight. But after
Mm,
4 months, you're saying the child and the eye is straight, meaning the eye is now better developed.
mm. So neuromuscular development, sometimes even attention.
Yeah.
Dr. Para said he needs explanation on the statement that before cover test. Yeah, okay, I think you've answered it. There must be bifoveal fixation.
Yes.
If the deviating eye is counting fingers, how will cover and uncover test be done appropriately?
So I didn't get that.
If the deviating eye is counting fingers, the visual acuity in the deviating eye is counting fingers, how will cover and uncover test be done appropriately?
Okay. The no, we will have to do at distance and near. For the distance, the deviating eye should at least be able to perceive the object of regard. So the object is put at that distance. But if the vision is very poor, remember that I said the criteria for performing the cover tests, the eye should have good vision, should be able to fixate properly. So if the vision is so bad, you may consider doing other tests instead of the cover test.
Yeah. But is it possible to do the cover test for the near?
For near, yes.
Yeah. All right, we're counting fingers. And I think during the presentation, you highlighted the importance of doing the cover and cover test for distance and near. As you highlighted for intermediate exotropia, they have a larger angle of deviation at distance. Similarly,
Yeah.
in near, accommodative ET, esotropia may also be more manifest in near compared to distance. So, well, this is a commendation. Very well done, Dr. Theresa. Excellent presentation by Professor Adu.
Thank you, Ma.
Yeah. Then, Dr. Asma, thank you for the presentation. At what age do you test for binocular single vision and the test for stereopsis? Okay, somebody is touching. Sorry, we'll reach out to people to talk. Dr. Teresa, can you go ahead?
Yes, please. Um, the for a child at least greater than one, because this, for instance, if you are using the synoptophore, the child the children are usually excited to see objects. It's like they are playing a game, or maybe put the bird in the cage. To them, that's a game. So a child that is able to at least um, do play such a game. So over 1 year, 2 years, you should be able to get um, findings for binocular single vision. Then for stereopsis, children that are able to cooperate for it, you can do the tests, because to them it's a game
Yeah.
and
All right.
children like games. So usually
Mm,
it's for most times for the verbal children.
mm, yeah. Thank you so much. Lots of commendations there in the chat box. All right. I think we'll give room for people that want to comment or make verbal contributions. They can unmute their mics and have the floor. Or they raise their hand, we recognize them for one or two. Dr. Panchak, are you here? Dr. Diamond. Yeah. Okay, Prof wants to go first. Okay, Prof Ma. Yeah.
Hearing you.
Dr. Teresa, I think you can stop sharing your screen.
Okay.
Yeah. Prof Ma, you have the floor.
Can you hear me?
Yes, we can hear you now.
I wanted to talk
Oh,
about the examination of someone cannot be chart that was asked that somebody said counting fingers. Now the reflection test, I mean the cover test is only be done but test should only be done for those who can actually read the chart. It cannot read the chart. Agent reflection test. That's the right. If someone has something that you want to do cognitive test because they want
sorry, Prof. I don't know whether it's my own end. The audio isn't very clear. Dr. Teresa, could you hear Prof clearly?
No, I didn't hear clearly.
Okay. I think maybe network.
I will send a message.
Oh, thank you so much, Mom. We appreciate it. Yeah. Okay, thank you so much, Dr. Ezin Onebune, for sharing that vital information on Bruckner test and the reason why the VT9 has a lighter reflex. I believe people must have read it. All right. We would like to appreciate all young ophthalmologists here for being with us. In another fortnight session, we know strabismus is large. It's not feasible for us to finish strabismus in an hour. Dr. Teresa had made it so interesting, as if in the next fortnight session, we should come back and continue managing these children we've evaluated. But we look at it at the academic committee, Dr. Ekule, Dr. Adele, able to see where are we going from here. All right, so we have a comment from Prof. If someone cannot read a chart, then use the modified Krimsky test. Okay, thank you so much. Dr. Teresa, do you get it?
Yes, sir.
All right. So we appreciate everyone, most importantly the presenter, for the hard work, for putting a lot of effort, for making Squint lecture very interesting. None of us was sleeping. All our eyes were on the chart, hearing the explanations behind all the scientific justification and reasons behind most of those tests, how to interpret the tests, and how they can help us to manage our pediatric patients well. I think strabismus is not only for pediatric ophthalmologists, but even the general ophthalmologist needs to know how to evaluate because of the significance. Early detection, preservation of binocular single vision, prevention of amblyopia, improving quality of life. So we really appreciate you, and on behalf of all of us, from where we say thank you. We see you another time. All right, bye-bye.
Thank you.
Thank you, the presenter. Thank you,